Leukamoid, leukemia plus oid, oid means resembling or looking like. It's a condition, reactive condition, which looks like leukemia, but actually not leukemia. This is a reactive process. This is a non-neoplastic process. On the other side, leukemia is a neoplastic process. What kind of neoplastic process? Malignant neoplasm. It's a cancer. Cancer originating from the bone marrow, affecting the hematopoietic precursors. So that is the leukemia. And it is often characterized by high WBC count. Now, leukamoid reaction is not leukemia. It's not a cancer. But it's also characterized by high WBC count due to a reactive process, often usually due to some severe bacterial infection that is the precipitating cause. So these are conditions which, as presents with high WBC count, exaggerated leukocytosis, severe leukocytosis. Leukocytosis means high WBC count. Anything ending in hematology with osis means high count of that. Anything. Thrombocytosis means high thrombocyte count. So this condition, that is the leukamoid reaction, it apparently, as it presents with very high WBC count, there is a cutoff limit also, more than 50,000 per cubic millimeter or microliter. With a very high WBC count, that's why it is confused with leukemia, particularly chronic myeloid leukemia, and it is called as leukamoid reaction. I think you have seen a set of words which are used in pathology or medicine ending with OID, epithelioid cell, seen in the in the granuloma, which are actually macrophages, not truly epithelial cell, but look like epithelial cell. That's why I call epithelioid, epithelial plus OID, cuboid, like cube, cuboid appearance. So similarly, this is a leukamoid reaction, is a reactive process where there is a typically high WBC count is seen. And when we talk about leukamoid reaction, we usually basically mean myeloid leukamoid reaction, because there is a high myeloid series WBC count, particularly the high number of neutrophilic leukocytosis is seen, high count of neutrophil and the precursors. And this condition is characterized by CYP2 left. That means not only we see high WBC count in leukamoid reaction, we also see a lot of immature form of neutrophils. I think you have know that the normal progression, the life cycle of, if you call it life cycle of neutrophil, that first there is myeloblast, then there is promyelocyte, then there is myelocyte, then there is metamyelocyte, then there is band form and mature neutrophil. So it is going like this: myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, mature neutrophil. Going from left to right, as I mentioned: myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil. And mostly when we see a normal person's peripheral blood smear, the series is shifted towards the right. That means we mostly get mature form of cell. So whenever the term CYP2 left is used, it basically means that we are getting a lot of immature cells, because immature cells are in the left side of the series. If I put it on the whiteboard to explain this, this looks like this. So that's why the term CYP2 left with high WBC count, the term is used for this. So the term is leukamoid reaction. That means you need to break and reaction, because it's a reactive process, usually due to some severe bacterial infection or due to some drug, due to some hemorrhage. I'm going to discuss about this shortly. That's why this term is leukamoid reaction. And mostly what kind of leukamoid reaction we see, that is called myeloid leukamoid reaction. That is the usual leukamoid reaction we see, because myeloid cells proliferate. So this leukamoid reaction basically is made with, as I mentioned, leukemia plus oid. Oid means looking like. So it's apparently looks like leukemia, this myeloid leukamoid reaction or simple leukamoid reaction. That is the idea. And this condition is typically characterized by greater than 50,000 per microliter WBCs, leukocytosis. Normally, you know, it is 4,000 to 11,000. That is the normal. Normal is WBC count is 4,000 to 11,000. So this condition is characterized by very significant, very high leukocytosis. 4,000 to 11,000 is the normal. This one is characterized by more than 50,000. And we get neutrophilic leukocytosis, lot of neutrophil, mature neutrophil, along with their immature form. Leukocytosis with SIP to left. Now I would explain the term SIP to left here. So normally if I see the series of progression of the neutrophil, how it progresses from the myeloblast stage to mature neutrophil. So first there is myeloblast, then there is promyelocyte, then there is myelocyte, then there is metamyelocyte. I think better if we could put in a straight line, then it would be easy to explain actually. Yeah, like this. Myelocyte, metamyelocyte, band form, and mature neutrophil. So let me put it in a straight line. It would be easy to explain now the concept. Anyway, now you see if I try to show this, that this series is normally shifted towards right because we are getting mature neutrophil. Normally they're shifted towards right. But when we use the term shift to left, basically we mean that we have started to see a lot of immature cell. So the term shift to left, whenever it is used, it basically means increased number of immature cells, because immature cells are in the left side of the series. So that is the concept why in leukemia reaction we use the term shift to left. That means we see high neutrophil count, more than 50,000, WBC count, high leukocytosis, majority of them neutrophil, mature neutrophil along with some immature forms, and that is why the term shift to left. And it apparently looks like, feels like, smells like leukemia, particularly chronic myeloid leukemia, but actually it's not. That's why this condition is known as Leukamoid reaction, a condition which is resembling leukemia, but actually not leukemia. Now I also tell you the differences between CML and leukemia reaction shortly on this whiteboard. But try to understand before that the differences between CML and leukemia reaction. And then I would go to the board again and I would explain this. So now you have a basic idea that leukamoid reaction is basically, it's a reactive process, reaction to mostly due to some infection or inflammation or some drugs. It could be certain bacteria are quite notorious, like Clostridium difficile, usually causes leukamoid reaction. It has been seen the pneumococcus can also cause, salmonella can cause. Certain bacteria is prone to cause very, very high WBC count. Prone to cause, Clostridium is particularly notorious among them. That could be due to certain drugs like recombinant colony stimulating factor, minocycline. So these kind of drugs actually can cause this. Recombinant colony stimulating factor is very simple because they stimulate the bone marrow to release more of them. And as a bone marrow, as an infection, you know that usually they're present with very high WBC count. When I think in this way, that when you are attacked, when you are suffering from severe infection, and so in the battlefield, the body needs more WBC. So and a lot of WBCs are dying. So what's happening? the body is basically calling even the immature WBCs from the bone marrow to come and increase their strength of the army against the bacteria. It's something like that, that if two countries are fighting, and in one country, if there is certain decrease in the number of their army because they are dying in the battlefield, what they would call that, they would even call the civilians. Civilians means those who are not soldiers to join army and go to the battlefield and fight them. Something like that. Even the immature people who are not exposed to who are not true soldiers in that sense, not army men, but they're still called in the immature state and brought to there. So this state actually, where we see that there is a very high WBC count, particularly in the setting of bacterial infection, and looking like it's a reactive process. It's a mostly a transient process, because if you treat with antibiotic and other things, again, this WBC count would come back to normal. This condition is called Leukamoid reaction. It could be due to many things I told you. It could be due to severe bacterial infection, sepsis. It could be due to some drug reactions like recombinant cornerstone-stimulating factors. It could be due to certain even cancers, as their paraneoplastic syndrome. They can cause leukemoid reaction, like lung cancer, oropharyngeal cancer. So this is a part of paraneoplastic syndrome because they release colony-stimulating factor to certain cytokines which can cause that. But leukemoid reaction itself has nothing to do with cancer. It's a reactive process where there is a high WBC count, more than 50,000 per microliter. And usually when we talk about leukemoid reaction, we talk about myeloid leukemoid reaction because there is a high WBC count, particularly the neutrophil, and seen with the CYP2 level, all these things I explained. It could be also due to some severe hemorrhage, retroperitoneal hemorrhage and other conditions, drugs. These are usual causes. Infection, particularly certain bacteria like Salmonella, Shigella, and Clostridium. These are notorious for. Now the next thing comes is that this is called leukemoid reaction because it's often confused with the leukemia, and particularly chronic myeloid leukemia is its differential diagnosis. Also chronic neutrophilic leukemia, CNL, it's also a differential diagnosis, but CNL is not so common, very rare. So mostly we compare this with chronic myeloid leukemia, CML. And now my next important discussion would be that how you can separate CML from leukemoid reaction. It can be done by very simple processes. First, look at the patient. The patient in a leukemoid reaction would be a severely ill patient who has acutely developed some kind of severe sepsis, maybe hospitalized, and they are having this sudden rise, abrupt rise in the high WBC count. Because if you check their WBC count 2 months back or 1 month back, it was quite normal because there is sudden rise, sudden abrupt rise in the WBC count. That would be the background for them. And you would be getting a precipitating cause, which is causing this leukemoid reaction. It could be due to drug or something else in case of leukemoid reaction. On the other side, CML, it would be different. CML, a lot of patients could come as asymptomatic. If they're symptomatic, they can have weight loss, they can have fatigue, they can have sweating. Many of them can present with some kind of abnormal dragging sensation in the left side of the abdomen. So due to massive splenomegaly. So physical examination, massive splenomegaly could be a helpful clue to differentiate CML from leukemoid reaction, because leukemoid reaction usually don't have massive splenomegaly. It's not a chronic process, usually due to acute process. But CML patients, often we get they present with massive splenomegaly. So looking at the patient's backdrop, that one patient, leukemoid reaction patients are usually having severe bacterial infection or sepsis, hospitalized, severely ill. CML patients, when they are usually caught at the initial stage, they are not so seriously ill at that point of time, most of them. Many of them are actually asymptomatic. They present with this kind of features like malaise, weight loss, and all these things. So these two features could help you. Now come to the diagnostic part, lab diagnostic part, how you can differentiate CML from leukemoid reaction. So CML from the leukemoid reaction, you can actually differentiate by this, that start with the peripheral blood smear. In the peripheral blood smear, in the CML, the WBC count would be often very, very high, in 6 digits, more than 100,000. Even could be closing to 1 million. It is also possible in case of CML. In case of leukemoid reaction, it's high, significantly high, more than 50,000, but usually not in 6 digits. And it's often not more than 150,000. That is not there. So it would be mostly in the range of 50,000 to 100,000. This range you would be seeing this leukamoid reaction. But in case of CML, it would be very, very high. In the cases of CML, you'll be getting peripheral blood, increased number of basophils and increased number of eosinophils. Peripheral blood, basophilia and eosinophilia would be seen. That would be absent in leukamoid reaction. Leukamoid reaction is usually not associated with basophilia or eosinophilia. That means on peripheral blood of the patient in CML, you'll be getting high number of eosinophil, high number of basophil. That would not be seen in this condition. Then another test which was used to be done, but nowadays is not so popular, that is called lab score or NAP score. Lab score or NAP score, usually we take a score of 100 neutrophil. We see their granules by using a test, lab score, leukocyte alkaline phosphatase score or neutrophil alkaline phosphatase score. And maximum score is possible is 400 because each neutrophil is scored from 0 to 4. And we check 100 neutrophils. So the maximum score is 100 into 4 is equal to 400. And normally this score is usually 35 to 100 out of 400, which I already told you. But in cases of CML, the score is usually low. But in cases of leukamoid reaction, the score is high. So this score is also useful to differentiate between CML and leukamoid reaction. It would be high in the leukamoid reaction and low in CML. I'll be discussing about the lab score or NAP score in a separate session because it requires time to discuss and explain the total concepts. The next thing right now, the best test which you usually can do is obviously to look for the BCR-ABL1 gene, the BCR-ABL gene, or the Philadelphia chromosome. So at the level of cytogenetics, we can differentiate leukamoid reaction easily from the chronic myeloid leukemia. And for chronic myeloid leukemia, the tests are available, like sophisticated tests are available, like FISH, fluorescent in situ hybridization, or reverse transcriptase PCR. These tests are available, which can pinpoint the diagnosis of CML quite easily. So I think there are plethora of ways, plethora of tests is there are possible to differentiate CML from leukamoid reaction. Let me summarize those things which can help to differentiate CML from leukamoid reactions for you. So let me clear all these things first. So this is CML and this is leukamoid reaction. So what are the differences? CML is a neoplastic process. It's a cancer. It's a reactive process, leukamoid reaction. It's not a cancer. That means CML, leukemia is a cancer. It's a cancer. Not a cancer. Now, CML, the leukamoid reaction, I told you the presentation would be in a severely ill patient, usually with severe infection or sepsis. There's a most common backdrop. Could be due to some drugs and other things. In CML patients, presentation could be asymptomatic many times, 20 to 50% cases they could be asymptomatic, could be due to some fever, weight loss, malaise, and features of splenomegaly. Splenomegaly is a characteristic feature, massive splenomegaly. Thus, splenomegaly would be absent in the patient here. In CML, next, there would be peripheral blood smear. There would be basophilia, eosinophilia, and strikingly high leukocytes, very, very high WBC count. This would be absent here. Here the blood, there would be no basophilia, no eosinophilia, and blood count would be high, more than 50,000, but not often as high as CML. This will be the differentiating feature. Even in the bone marrow, there will be a lot of differentiating feature you can see, but that's not necessary actually. Lab score usual test is done. The lab score is usually low in CML and high in Leukamoid reaction. The idea is this, that why they're high or low, because they think that the Leukamoid reaction, the neutrophils are still more mature compared to CML. And if the neutrophils are more mature, then the lab score would be high. That is the concept. In CML, the neutrophils are not so mature. Cytologically, cytochemically, they're abnormal. That's why they don't have enough alkaline phosphatase. That's why the score is low. And obviously, the differentiating feature in CML, that would be cytogenetics. You can have Philadelphia chromosome. You can have BCR, ABL1 gene or the fusion gene, which would be absent in the Leukamoid reaction. So these are the basic differences in a nutshell between the CML and Leukamoid reaction. And obviously CML, this process would be quite progressive, the high WBC count. While the Leukamoid reaction, it would be transient and abrupt. And if it is treated promptly, it would come back to the normal range. So suppose a patient has having severe sepsis, but is promptly treated, taken care of, proper antibiotics are given, so it would come back to normal range. That would not happen in the cases of CML immediately, obviously, by treating with antibiotics. So we learned about the key concepts of the Leukamoid reaction, that basically it's an reactive process where there is a sudden rise in the WBC count, particularly when we talk about Leukamoid reaction, we talk about myeloid Leukamoid reaction, because there is sudden rise in the neutrophil leukocytosis occurs. Usually the leukocytosis is more than 50,000, and it's usually caused by some severe bacterial infection, sepsis, could be due to hemorrhage, could be due to certain drugs. And their main differential diagnosis is chronic myeloid leukemia. And these are the ways, I already explained that how you need to differentiate them. So that's all the key concepts about the Leukamoid reaction in a nutshell. And we'll be discussing about the other concepts of the leukemia and lymphoid in the coming InstaLectures. Thank you very much.